Okay. Good morning, everyone. You are going to learn something different from what you have learned all these years. So it will be a very informal or very formal, whichever way you like, interactive session. If I tell you something you don't understand, you ask me back questions. If I tell you something you understand, you ask me questions to make you understand better. So it's going to be interactive session. So don't get worried about what I am going to ask you. I have 40 years of experience in ophthalmology, so I obviously must know better than what you people know. Yes? Or doubt very much? Okay. Orthoptek is an instrument which is useful in treating amblyopia and related disorders. Now, till now, you have learned that amblyopia is untreatable, correct? Or you can partly treat it with patching, and that's about it. Yes? Anything more you know about treatment of amblyopia? Okay, anything you know about the diagnosis of amblyopia? How do you say it is amblyopic eye? Anyone, just take a guess. Why do you say it is amblyopic eye? When the vision between the two eyes is different and one of them is less and it cannot be corrected by doing anything, by doing refractive correction, by doing any other alternative measures, you cannot improve the vision. Maybe the diagnosis is amblyopia. Okay. So all these years, the concept was amblyopia is untreatable. It's no longer true. Amblyopia is treatable and is a curable condition with this instrument, which is called Orthoptek. Any of you read Dr. Kurana's book? You can buy the recent book on ophthalmology by Dr. Kurana for undergraduates. It gives you one paragraph about Orthoptek. Okay. Now you can see the effect of the Orthoptek treatment. Within 2 sessions, the patient starts seeing better. Within 2 sessions of 1 hour each, he can see better. It's something unheard of. You can do patching for months together, but still the vision does not improve. But this one, within 2 sessions, the vision improves. I'll explain to you later why that is so. And the full course of treatment lasts for about 2 to 3 weeks, depending on the age group. Okay. The instrument is very easy to set up, and even children as young as 4 years can use it. And obviously adults, unless they have brains like somebody who is a leader of opposition in parliament, then he cannot use it. You explain anything to him, you stand behind the Orthoptek and start using it. It's easier to give treatment because you don't need a doctor to be there when you treat. And it's even easier to buy. You just have to send me an email and money, you will get the instrument within 1 week. And it's not heavy on your purse because I have not yet sold it to a private company which will charge you heavily for this instrument. The indications for use of this are many, like amblyopia of all types. What are the types of amblyopia? Strabismic amblyopia, anisometropic amblyopia, congenital cataract, amblyopia and congenital cataract, fourth and sixth nerve palsies in adults, intermittent divergent squint, and in dissociated vertical deviation. It's also used in recurrence of exotropia after surgery and in nystagmus, and some cases of optic atrophy, and some cases of congenital iridomacular dystrophy, and post-squint surgery movement limitation not due to muscle slippage. So you can see how many indications are there. So it is useful even for a general ophthalmologist to buy this instrument and use it. And financially very viable as of now. When I get bored, I'll sell it off or wash my hands off and say, you do what you want. If I sell it off today, he will sell it to you for 4 lakhs, not less than 4 lakhs. Because I'm not going to sell it anymore, then you end up paying more money. For as long as I am selling, it will be less because I am the inventor, manufacturer, and distributor of the instrument. There is nobody else who does this. Okay. Now financially you can recover the cost of this within 2 to 3 weeks. Many people have recovered within 2 weeks and they have bought one more extra instrument. And the video shows how to set it up. It's very easy. It is on a wall, you hang it like you hang a flat TV screen. So you fix the clamp, on the wall you fix the thing onto the wall, part of the clamp, at about 3 feet from the ground level. The lower end of that must be about 3.5 feet. So when you hang it, it comes down a bit. The reason why it should be, I'll explain to you later. This is how it looks like when you have fixed it. This is what is Orthoptek. I'll show you some more instruments, and you can see a child. This child is with intermittent squint, aged only 3.5 years. She's doing it. After explaining how it needs to be done, she is happily doing the exercise without any help. So you don't need an eye specialist or a doctor to explain to the patient when they are doing it. Once you have explained, they understand it better. And you can see this child doing it with fingers. The child I was very worried about giving laser pointer to the child. So what I did was, I said, you point out the light which comes on with fingers, and you can see the child pointing out with the fingers. That also improves the hand-eye coordination. Now, why the hand-eye coordination improves with vision, I'll come to you a little bit later. Now, this is where the difficulty of the instrument starts. Just show before we go to that, just show the videos, please. Right. You can see the adult patient doing this. She reduce the volume.
Volume.
The patient is made to sit at a distance about 3 feet in front of the machine. You can hear that. In such a way that the eye is in primary position at the level of green light on the board. And because of this reason, the height adjustable chair is necessary, and they will be provided with a laser pointer to point at the light which comes on. Okay, you saw that video, how it is done. Why that second video you can show. Why the patient should sit in front of the thing about 3 to 4 feet away from the machine. Orthoptek has 2 programs, and the patient does each program for about 15 minutes to 20 minutes with the normal eye covered and with the ambulatory open, and then with both the eyes open. In one program, which is going on at the moment here, you can see the red light and the green light are blinking. So the green light is blinking and the red light is going around in circles, like what is shown here. You can see that. The patient is asked to concentrate on the blinking green light. Now for this, the patient has to be quite aware of what he is doing, and any child over the age of 5 years will understand this program. This is called as forward attention, wherein the patient focuses on the flashing green light and keeps the eye focused on the flashing green light, but is still able to count the red light which is going around. You try that now while it's going on. You will be able to do that. This is forward attention. In this program, the patient counts the red light only and keeps looking at the green light about 800 times with the ambulatory eye and with about 600 times with both the eyes open. When the ambulatory eye is open, the normal eye is patched or covered with an occluder. And when both the eyes are open, there is no need for occluder. Now in this program, there is no need to use the laser pointer. In only its next program, which I will show you soon, you need to use the laser pointer. The reason why we give laser pointer to use in the other program is because the hand area is close to the frontal eye field area in the brain. You understood that?
Because of which the hand movement and eye movement are closely interrelated, and this in turn stimulates the top-down impulses from the frontal eye area coming to the occipital area. And this improves not only the handwriting because of improvement in hand-eye coordination, but also it improves the visual acuity in the amniotic eye because of the stimulation of the occipital cortex by the top-down impulses.
Okay. So you understood up to this point. You understood what is covert attention and what is overt attention. When the eye moves towards the object of interest, you can see the eye movement, then it becomes overt attention, where it's visible. Overt means visible. Covert operation means invisible, where the patient's attention is to the red light, but still the eye is not moving. See, I'm looking at you, I can still see her, I can see him, that is covert attention, but not the details. I cannot see the details, but I can still see grossly what is there. Now, how is this possible? The attention area, that we will come to that in a few minutes. If you understand this, you understand the entire mechanics of vision. See, in the vision, in the retina, there are two types of cells. One P cells, that is parvocellular cells, and one M cells, which is magnocellular cells. The two have different functions and they two have different morphology also. It's not just that both the retinal receptors look the same. No, they look different and their functions are different and they go to different parts of the brain. It's important to understand. Nobody would have taught you so clearly certain aspects about vision, which is essential to understand why Orthoptek works so quickly. You have all been taught, oh, amblyopia, we just patch the eye, send the patient home and ask him to come back after 1 month. Not necessary. I ask them to come back next day and check the vision will be better. Why that is so? I'll explain to you. So you know that the central cells are called P cells or the parvocellular cells, which are in and around the fovea, and the peripheral cells are the M cells or the magnocellular cells, which are beyond 10 degree of the fovea. Then there are P-looking M cells, M-looking P cells, and then the coniocellular cells. We need not go into further details for your undergraduate examination. If your undergraduate examination, if you know P cells and M cells, that is more than enough. Now the P cells go to lateral geniculate body, layers 3, 4, 5, 6. P cells concentrate on the fovea, so they get a larger representation. The central retina gets a larger representation in the central nervous system. The peripheral retina gets a smaller representation in the peripheral. This entire course is only me, nobody else is there. So the peripheral retina goes to a smaller area in the brain. M cells go to a smaller area. P cells go to a larger representation because P cells function to identify the object. The details of the object are by the P cells. Now the P cells, if they have to identify the object, they have to be seen properly, and that goes, therefore it goes to a larger part of the occipital cortex. And that is shown by LGB, where they are in layer 3, 4, 5, 6, whereas M cells go to layers 1 and 2 only. LGB is what? LGB is what? Lateral geniculate body. It is a part of the thalamus. You need to know why it is a part of thalamus. I will come back to that in a few. So in order to understand all these things, what you need to do is go back to your MBBS days, anatomy days, take out Cunningham volume 3. Is Cunningham still made? The dissection, anatomy dissection book, take out volume 3 and read about brain. The best information is available in that book. Don't immediately take out Gray's Anatomy and start reading, you will be lost forever. Only volume 3 you take out and read about brain in that volume 3. Now from the lateral geniculate body, the geniculate fibers, the calcarino-geniculate fibers, they go to the occipital cortex. Now where in occipital cortex they go to? Any idea, any clue? Where exactly in occipital cortex the P cells go to? P cells go to layer 4C alpha, that means 4C beta, because in the occipital cortex there are 6 layers, 1, 2, 3, 4, 5, 6. And out of these 6 layers, the layer 4 has got 4A, 4B, 4C. Out of this again 4C has got 4C alpha, 4C beta. You understand? So the P cells go to 4C beta, whereas M cells go to 4C alpha. You see how there is a dichotomy of vision. Although it is going from retina to the occipital cortex, they go to different parts of the cortex. The P cells go to 4C beta and M cells go to 4C alpha in occipital cortex. But the vision just does not end at occipital cortex, because the occipital cortex is like Manmohan Singh. It is not able to analyze anything. It will just pass on the file to the higher command, and the higher command is not as brainy as this brain. Okay, so where does it pass the information coming from occipital cortex? It will send to the temporal cortex. The P cells go to temporal cortex. Do you have a pointer? Or in this one also? Okay. It will go to inferotemporal cortex. The inferotemporal cortex, it doesn't come there. It will go to inferotemporal cortex for analysis. See, the brain has only action potentials. That's all for analysis. So the brain analyzes these action potentials in such a way that the red shirt and blue shirt, if they are different, the brain is able to recognize that they are different, although they look the same. Or one black shirt and another black shirt with different design, the brain is able to recognize they are two different things, but they are the same black. You understand the point? See, I am wearing black, you are wearing black, but you know that these two are different. How do you know these two are different? Because the action potentials coming from this dress is different from action potentials coming from your dress, which the brain is able to understand and recognize the difference. And that is possible only because of the inferotemporal cortex. So final visual analysis happens not in occipital cortex. Occipital cortex is just an image transferring center. It just transfers it to inferior temporal cortex and says, you please have a look at it. I don't know what it is. So the impulses are going like this. What the occipital cortex is, that make them straight like this and send them off. Groups them together and send them off to inferotemporal cortex for analysis. Now why am I telling you all these things? Because I will tell you when I tell you about Orthoptek. So you need to understand these things before you even design. How did I design Orthoptek? Because during COVID time, neither I was seeing patients nor I had patients, so I had a lot of time. So what I did was I sat in front of the books and started reading. And then a lot of questions started coming in my mind. Nowadays, these questions, they can be put to ChatGPT or Grok or something like that, and you get immediate answers. It's very easy nowadays, but not those days when there was no ChatGPT. Although AI was there, but it was not as prominent as it is now. So the inferotemporal cortex analyzes the information from the central retina. So what information is coming from central retina? Size of the object, shape of the object, surface of the object, color of the object. Size, shape, surface, texture, color. These 5 things are coming from the central part of the retina. The peripheral part of the retina shows only motion and position. The M cells deal with motion and position. But the occipital cortex receiving the M cells cannot understand what the M cells are saying. So what it does, the occipital cortex, is it sends it to superoparietal cortex. So superoparietal cortex analyzes the position of the object and movement of the object. Is there movement or there is no movement? If you are moving, you are nodding your head, my peripheral cells are able to see that quickly. Yes, somebody is nodding their head. And somebody is sleeping and nodding their head, the peripheral cells also see that. Why these things are important to understand is important because you need to understand the whole concept of vision and what the brain does to make you see better. Okay. Now, once the supraparietal cortex and temporal cortex receive information, final information they have. I'm seeing the orange shirt there. I'm seeing the black dress here. This is the information the inferotemporal cortex has got. Now, what am I supposed to do with the information? They will ask. I don't know. Send this to cognitive center, which is in the front part of the brain. They send all this information to cognition center. The cognition center then makes decisions as to what should be done. It says ignore. So all right, ignore. No, 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 it's very interesting. Look at this, not that. Then they move the eye. You understand? I'm trying to simplify the whole concept of eye movement and vision as much as possible for you to understand the orthoptek. Okay, so what the temporal cortex and the supraparietal cortex, they both do is send it to the parietal cortex, posterior parietal cortex. The other is called PPC. Now, primary posterior parietal cortex is important because that's where the sensory motor integration happens. You have taken loan from somebody. You see that fellow from a distance. The information is sent to cognitive center. The cognitive center sends back to the parietal cortex and say, give some information to the legs to run away from him. You haven't paid him for a long time. You better run away. So you turn the whole body and run away from him. Now that is possible because of connection between cognitive center, parietal cortex and motor cortex. That's why posterior parietal cortex is called as the great sensory motor integration center. Am I making any sense to you at all? Yes? In simplest terms, I am trying to explain to you. And that's why our ancestors said, Sarvendriyanam Nayanam Pradhanam. Of all the organs, the eye is most important, they said. That's because of this. You can see how eye is connected to all parts of the brain, not just one part. Cognition part, parietal cortex, occipital cortex, temporal cortex. Every part of the brain is connected to the eye. So therefore, if you do functional MRI, when the person is looking at the object, all parts of the brain you can see the stimulation, not just occipital cortex. As ophthalmologist, our interest stops at occipital cortex, and that too it doesn't go into the depths of where in occipital cortex because we have no interest in going beyond that. But actually, the vision does not start or stop. The vision starts at retina and stops at inferotemporal cortex and goes beyond. From inferotemporal cortex, it has to go to cognition center and it has to go to posterior parietal cortex. Then only the vision makes sense. Otherwise, vision does not make any sense. I'm looking at the time, don't worry. Okay. So 10:15 I have to close, right? So I'll keep at 10:10 and 5 minutes questions. So be prepared and listen to it carefully. So now you realize the information from both temporal cortex and supraparietal cortex come down to the posterior parietal cortex area 7A. Okay, I won't ask you questions. You can go, don't worry. Okay, don't worry, go. So the information comes to posterior parietal cortex, to an area which is called attention area. That is, area 7A is the attention area. This attention area is what decides where the eye should be looking. I was looking at three girls and they went away. Now our brain doesn't know where to look at. So you are the only person who is there now. And that gentleman, you can come in front if you are interested. Am I making any sense at all? Still you can come in front. I'm telling you in such simple words anybody can understand, correct? So area 7A is the attention center. What the area 7A does as attention center is it tells the eye, look, this object is interesting, turn the eye towards that. Or look, this object is better ignore, not interested. Okay? So when the brain tells the eyes, how does the eye move? It has to tell the motor centers. The brain has to tell the motor centers, this object is interesting, look at it, or this object is interesting, don't look at it. Okay, so this is where the top-down impulses come which help the Orthoptek. I have marked a figure from frontal eye field area. From the posterior parietal cortex is connected to the saccadic generation center. Here, okay? From the posterior parietal cortex, it is connected to the saccadic generation center within the parietal cortex. This saccadic generation center, when it is stimulated, it sends impulses to the frontal eye field area and it moves the eye. So saccadic generation cognition center sends information to the posterior parietal cortex. The posterior parietal cortex sends information to saccadic generation center. The saccadic generation center sends impulses to frontal eye field area and say, move the eye towards that side because that is the most interesting object I have seen. So the eye moves towards that object. Now, temporal cortex, when it is strongly stimulated, the temporal cortex is analyzing what kind of shirt you are wearing, what kind of specs you are wearing, what kind of bag you are carrying, all the details it is analyzing. So the temporal cortex needs more time to analyze. So it tells the posterior parietal cortex, hang on boss, I am looking at something very interesting. I don't want to move the eye. The information goes to parietal cortex saying, don't move the eye. So the parietal cortex, what it does is it sends impulses to the saccadic generation center and inhibits the saccadic generation center. You see how God is clever. Okay? If you stimulate the central retina, the eye does not move. If you stimulate the peripheral retina, the eye moves. And a balance between the movement and stationary eye is what leads to perfect vision. But imbalance is what leads to nystagmus. The eye is focusing something and the inhibitory impulses to the posterior parietal cortex, saccadic generation center somehow is reduced. Then the eye moves. And then this temporal cortex, hey, hold on, I never asked you to move. And the eye moves back. Then moves back. You see what is happening to the eye? That is nystagmus. So the problem in nystagmus is somewhere here, and here. That's where the problem is in nystagmus. See how complicated the eye becomes just to understanding the vision. Okay. Now, if you try and understand this This is even more complicated. I cannot simplify it at all. However much I try, I cannot simplify this part of the central nervous system part of the vision. But I'll try. From the parietal lobe and the frontal eye field area, top-down impulses come. That is, impulses come down from the parietal lobe and the frontal lobe to the occipital lobe. It's a two-way system, not one way. Now, they go to 4C beta layer. And if you remember, 4C beta is where the central cells discharge onto. And they fast forward the impulses of the 4C beta going to infratemporal cortex. And 4C beta is where the amblyopia problem is, and therefore the amblyopia gets treated within a short time. You can ignore this, except that synaptic transmission is the problem at 4C beta level in occipital cortex in amblyopia. What is the problem? Well, the synaptic transmission is dependent on a substance called glutamate, which is released at the synapses. If excessive glutamate is released, it damages the neurons. If no glutamate is released, then it does not pass the information on to the inferotemporal cortex. The analysis of the information by the inferotemporal cortex is dependent on the glutamate released at the 4C beta synapse. Okay, now what is this N-methyl diaspartate receptor? Well, this is what takes up the glutamate. N-methyl diaspartate takes up the glutamate and nitric oxide is released. The released nitric oxide acts as a messenger just like glutamate, but it is faster than glutamate in crossing the synapse, and it is not blocked by glutamate destroying suppression. This is too complicated, no need to understand that. See, this is what it looks like in amblyopia. Transmission of impulses from the retina to the brain is normal. Up to brain it is normal, but within the brain there is an issue in amblyopia. And what is the issue? I have already explained. Therefore, the indications for use of Orthoptek. Where can you use this? You can use it in intermittent divergent squint, amblyopia different types, esotropia, loss of stereopsis, to improve hand-eye coordination, to treat or reduce nystagmus, and to treat ocular problems in cerebral palsy, and to treat dissociated vertical deviation and optic nerve problems and in congenital heredomacular dystrophy. These are the various indications in which you can use the Orthoptek. Let's see people who have bought Orthoptek from me and have paid fully in their money, what they felt about Orthoptek. One fellow wrote to me and said, you seem to have cracked the alpha and beta of amblyopia treatment. Kudos to you, I am a proud Indian today. He was very happy that some Indian has done something which is useful. And one fellow wrote, magic of Orthoptek, finger counting to 6-9, no patching, only with Orthoptek stimulation. No patching, that is an amblyopia. Another fellow wrote, bilateral ametropic amblyopia with nystagmus, vision enhanced to 6-6 and 40 seconds of arc of stereopsis with Orthoptek treatment. They voluntarily wrote this to me because they were very happy with treatment. Another wonder by Orthoptek, he wrote, amblyopia and hypermetropic amblyopia in a 20-year-old male improved from 612 to 6-6 in just 7 sittings. And stereopsis also improved, and we are happy, the patient is happier as he is going for army recruitment. And another fellow, like this, I have received hundreds of letters from all the 100 ophthalmologists who have bought. I can summarize in just 2 words, wonder gadget. Another fellow wrote, "You are come to us like a god." I said, "No, I am an ordinary human being with two legs and two eyes." So that's what the information given to me by the various people. To use Orthoptek and to fix Orthoptek is very simple. But to understand Orthoptek is very difficult. The most difficult thing is to understand why it works. But this picture will tell you why it works. This picture will tell you how the sensory thing is connected to the motor part. I'll show you the video how to use it in a minute. You can show him the video. Okay. That's why they called, our ancestors called Sarvendriyanam Nayanam Pradhanam. Now you understand why the eye is most important, because it is connected to every part of the brain. Occipital cortex, parietal cortex, temporal cortex, dorsal frontal cortex, and even DFPC, that is prefrontal cortex, caudate nucleus, superior colliculus, lot of areas in the brain is connected with the eye. There is a reason for saying that Sarvendriyanam. No other part of the body is connected to as many parts of the brain as the eye is. Okay. So you need to understand all these connections to understand why the eye moves, in which direction the eye moves, and by how much amount the eye moves. Now these are all not necessary for you to use Orthoptek, but to make Orthoptek I would have understood all these aspects. And then only I made Orthoptek, but still many pediatric ophthalmologists will say, "I don't believe what you have done." But the theory behind it is very solid. You cannot discount and say occipital cortex is not connected to parietal cortex, or parietal cortex is not connected to occipital cortex. You cannot disprove. But why that helps in Orthoptek, I'll show you. You can scan this code, you will get all the details, how to order Orthoptek, where to order Orthoptek. Okay, you can scan that, and how to fix it, I'll show you also. Show the videos
So this is our top tech,
for you.
which is fixed at a distance of 3 feet from the ground level. The lower end of the machine is, and it is fixed on a clamp which sits at about 3.5 feet from the ground level, and it sits on the clamp. It has got two programs which can be changed by pressing the red button here. In program 1, we can see lighting alternating with each other. The patient fixates with the amblyopic eye first, and with the normal eye covered, he points out the light like this. And this he does with the amblyopic eye 800 to 900 times, and then with the normal eye open 500 times. So he does first closing the normal eye, and then he does with both the eyes open 800 times with amblyopic eye open, and 500 times with both the eyes open. This is in program 1. This he does sitting at a distance of about 3 feet from the wall. From the machine, he sits 3 feet in front of the machine with the eye at the level of the green, which you see here. His eye should be fixed at this level. Now this is program 1. Once he does that 800 and 500 times, you press the button like this gently and leave it. Now you can see the green light is flashing and the red light is going round and round in circle. So this is program 2. Now when the patient fixating at the green light, still will be able to see the red light.
You can do that even now. Look at the green light, you will still see the red light moving.
900 times is going to count with the amblyopic eye and the normal eye covered. And then he leaves both the eyes open and he counts the red light 500 times with both the eyes open. In the second program, in this program, there is no need for him to show with the light like this. He just has to count the red light, keeping the eye fixed on the green flashing light which is flashing. This is program 2. So he does program 1 it as for 15 days for improvement, and then we can decide how to reduce the timing. Thank you.
Show the other video. So there are two programs. One, you look at the peripheral lights, but don't look at them. Look at the green light, and you can still see the peripheral light. The attention is now split between central and peripheral retina. The central retina prevents the eye from moving constantly to look at the peripheral light. But the attention area is receiving information from peripheral light also. So the attention is strongly stimulated by both peripheral retina and central retina, which are connected to the occipital lobe. So which in turn stimulates the vision. Show the other video. This is an adult, she is around 40 years old, she is doing the
And it's placed on a wall close to a power source like this. The patient is made to sit at a distance of about 3 feet in front of the machine in such a way that the eye is in primary position at the level of green light on the board. And because of this reason, the height adjustable chair is necessary, and you will be provided with a laser pointer to point at the light which comes on.
Okay, that's as simple as that. Doing this is very simple, but to understand why it works is very complicated. You need to understand the whole lot of brain and understand it. But in simplest terms, what I can suggest is, it's till what time this session? Hello? Session till what time? 10:15 or 10:30? 10:30. Okay, the simplest way to understand that this is, when the light moves and the eye moves, that is called overt attention. You can see the attention is diverted to a different object because of the movement of the eye. Now, in what way the movement of the eye is important? If the eye, there are various types of eye movements: convergence movement, divergence movement, saccadic movement, pursuit movements, etc. But of all these movements, the reflex saccadic movement, what happens here? The reflex saccadic movement stimulates the lateral occipital cortex maximum. If you understand the lateral occipital cortex, it has got maximum representation of the macula. So when the macula is stimulated, the lateral occipital cortex gets stimulated. So when the eye moves because of the saccadic movement, that in turn stimulates the lateral occipital cortex via the top-down impulses coming from the frontal eye field area to the occipital cortex. So whenever there is a saccadic movement, the lateral occipital cortex automatically gets stimulated. In amblyopia, that's where the problem is, in the synapses of layer 4C beta. When there is a problem in 4C beta, which prevents the transmission of impulses across to the temporal cortex for analysis, your vision is not good, because ultimately the vision depends on the connection between the occipital cortex and temporal cortex. Final analysis of vision happens only in inferotemporal cortex, not in occipital cortex. Occipital cortex is just a Manmohan Singh cortex. Just passes the file to madam and says, "Madam, please have a look at the file. I don't understand what is in the file. You take a decision and send me back the file." So the inferotemporal cortex analyzes the vision, sends it back to occipital cortex, the Manmohan Singh of the brain. Although he is brainy, but he used a brainless woman to help him. So the occipital cortex tells the brain again, send it to cognition center. So the temporal cortex sends the information to cognition center. because the final action as to what action should be done by the body is dependent on the cognition center. Whether you should look at the object, ignore the object, move the eye, not move the eye, all these aspects are decided by the cognition center. So therefore, the connection has to be perfect between the occipital cortex. Can you put that slides for a second? I'll tell you one more point. Since you are here, I have to tell you very interesting point about the nystagmus and occipital cortex. Let's come to, since you came late, you missed a lot of things. This is how you fix the Orthoptek. With the clamp, you hang it on the wall like a TV, and like that. We have changed the design for a specific reason. I'll explain to you later. And you can see the child age 4 years doing the Orthoptek exercises. Then you can see the child doing even less than 4 years with intermittent divergent squint doing Orthoptek exercises with fingers. Point out the light with the fingers. Now why with fingers? I'll tell you with certain important points. So if you look at this figure, from P cells go to layer 1, 2, 3, 4, 5, 6 of lateral geniculate body. From there they go to the layer 4C beta and occipital cortex. The layer 4C beta and occipital cortex does not analyze your vision. It just, the impulses are going like this. It just makes them like this and sends them to temporal cortex. What they do is they bind the action potentials of similar type together and they send it to inferotemporal cortex. The inferotemporal cortex in turn analyzes these action potentials and sends back impulses to the occipital cortex and also to cognition center. Because the inferotemporal cortex cannot decide the motor part, it's in the sensory part of the brain. So what it does is it sends it to posterior parietal cortex. The posterior parietal cortex is the great sensory motor integration center. The posterior parietal cortex decides whether the eye should move, eye should not move. Supposing you are going on a beach for walk in south of France. People who have been to south of France can understand this joke. Otherwise, you will never understand. You are going with your wife next to you. And south of France is a nudist beach, incidentally. So you are going with your wife. First of all, you won't go there. I have been and I was thrown out with my wife because we were wearing clothes fully. So you're going there and immediately your wife says, move back, let's go back. If you are with your wife, your brain will listen to you because your cognition center thinks, when I go home, I will have problems, better move back. So the cognition center says to the eye, move the eye away, we will go off from here. The cognition center also sends impulse to the leg muscles and says, turn around boss, let's go home. But if you are going alone, you will go like this continuously. That is the difference between cognition center and the occipital cortex. Occipital cortex cannot decide. It is the cognition center which decides. The cognition center has got cultural values, which decides what action should be taken by its connection to the parietal cortex. Why parietal cortex? Because parietal cortex is the sensory motor integration center. See how every part of the brain is connected with the eye. Cognition center is in the front part of the frontal cortex. Inferotemporal cortex is connected to the parietal cortex, is connected to the occipital cortex naturally. It's connected to the supraparietal cortex. It's connected to the subthalamic centers for movement of the eyes. It's connected to the muscles of the leg for movement of the legs. And that's how Orthoptek improves the vision and motility even in cerebral palsy. When I presented first time, does it do the function of Viagra as well? I said, I'll try that. I have not tried that, but I'll try that. Because I said it is connected to different parts of the brain. So it can improve the muscle tension even in cerebral palsy. So the indications for Orthoptek are, as I've given you here, amblyopia of different types, intermittent divergent squint, exotropia, loss of stereopsis for some reasons, to improve hand-eye coordination. Why it improves hand-eye coordination? Because the frontal eye field area is situated close to the hand area, so close that you cannot distinguish whether it is the hand area which is stimulated or the frontal eye field area. One stimulates the other. So hand area stimulates the frontal eye field area. Frontal eye field area in turn stimulates the hand area. So the hand-eye coordination improves in amblyopia using Orthoptek. It improves within 10 days. The children come out with fantastic handwriting, much better handwriting compared to what they were doing before. One child came and gave me a star. I asked her, why this star? Because my teacher gave me 2 stars for handwriting and I'm giving you 1 star for you because you improved my handwriting. Because it improves the hand-eye coordination significantly. Even in cerebral palsy, I've seen a child who could not write anything, started writing his name with the left hand. His name, he could easily write his name with the left hand, whereas earlier he couldn't use the fingers at all. But following Orthoptek treatment, he started using the left hand and wrote his name. That is the beauty of this instrument, that it works. Why it works, I told you. Why hand-eye coordination improves? Because of connection between the frontal eye field area and the hand area. Now, why frontal eye field area and the hand area should improve the vision? Because of the what is called as the top-down connections coming from the frontal eye field area, going to the occipital cortex and stimulating the fast forwarding of impulses across the synapse in the occipital cortex, where the problem is in amblyopia. Glutamate is released but not sufficient amount. Glutamate is released at 4C beta, may be removed rapidly by the various things. Glutamate is probably not, there are both glutamatergic and GABAergic neurons in the brain in occipital cortex. They are in balance. Excessive glutamate damages the nerves. It is extremely neurotoxic glutamate. Large amounts of glutamate released and stays in the occipital cortex for a long time. It causes degeneration of the brain. So glutamate must not remain outside the cells. It should be rapidly decarboxylated, dehydrolyzed, removed, uptake by reuptake, etc., etc. The glutamate metabolism is very essential in understanding vision. Glutamate is converted into gamma aminobutyric acid, which is GABA. GABA is inhibitory. So inhibitory neurons release GABA. The stimulating neurons release the glutamate. So excessive glutamate should never be left in the extracellular space. So in amblyopia, from the amblyopic eye, glutamate which is released is not utilized properly because of the damage that has happened. So it causes further damage if you leave it. So the brain starts an active mechanism of removing the glutamate from the amblyopic eye stimulation. And this is the mechanism of amblyopia. So however much you stimulate the afferent impulses by doing all kinds of things which they have explained to you, they are all useless because they do not do anything to the glutamate which is not released at the uh, level 4C beta, or not do anything to the excessive removal of glutamate at level 4C beta. The excessive removal of glutamate is an active process by the brain. You are not doing anything to that. But Orthoptek overcomes this via the top-down impulses, otherwise called as geniculocalcarine pathway. One is geniculocalcarine pathway, going from the geniculate body to the calcarine. The other is calcarino-geniculate pathway, which comes right up to the retina, and that's how the Orthoptek is helpful even in optic atrophy. even in congenital heredomacular dystrophy, and even in color deficiency. I've treated few patients with congenital color deficiency, color absence. It improves the vision but does not improve the color vision. I have a theory for that. It improves the vision because the abnormal color receptors in the retina, they die quickly. Since they die quickly, they also stimulate the surrounding ganglion cells also to commit suicide. So the surrounding ganglion cells also die along with the color vision cells. And this leads to decreased vision. But Orthoptek stimulates these ganglion cells to regrow. They stimulate to regrow because of the top-down impulses coming from the brain to the retina, which release nitric oxide. The nitric oxide is most essential for vision. Both in retina and in brain, nitric oxide is very essential and is released. You can chat GPT nitric oxide usefulness in the brain, where all it is released. I can explain to you Hanumanta's concept using nitric oxide, 10,000 times more powerful. Hanumanta is normally 10,000 times more powerful. What they were trying to say was nitric oxide is more powerful than oxygen in the brain for certain functions. And how do you say that? Give the example of Hanumanta, and people will say all rubbish. You don't understand a thing. Because how many of you have read Sanskrit? None. None. How many of you have read English? Everybody reads. So we don't know our own language, our own history, our own books. So we look down upon ourselves and say we are stupid. Our ancestors were stupid. But our ancestors were very, very brilliant. We are stupid not understanding them. Okay, these are the indications, and this is some of the things they have written to me about Orthoptek. These are all general. After I have 4 minutes, I'll finish in 1 minute, and 3 minutes you can ask any questions. This is the information they wrote to me, and they voluntarily wrote because they have already paid for it. I don't have to ask them to write. After using the Orthoptek, they wrote to me and said it's a wonder gadget. And when I used it on the patient, they were very impressed because after the second session, they said, I can see better. Now, why they can see better? Because of nitric oxide release in amblyopia. In normal eye, if you do this, it can be dangerous. Only in certain eyes you should do it, where nitric oxide is rapidly utilized and it doesn't damage the nerves. I think I have shown you the code to, yeah, there. You can copy that QR code. You will find all the details, but it can sometimes be very boring. Because I discussed a lot about NMDA receptors in the brain, how they release nitric oxide, how the released nitric oxide acts as a messenger like glutamate and stimulates the postsynaptic membrane 10,000 times faster than the glutamate, and therefore the vision improves rapidly. I think I have done my duty. Thank you very much. Thanks you for listening to me. Hope I didn't bore you. You have any questions, you have 3 minutes to ask me. Any complicated question you can ask. Sorry? I'm a bit hard of hearing.
How without patching it is working?
I explained to you, it's very complicated to explain. Without patching it works because of release of nitric oxide and glutamate via the top-down impulses. Top-down impulses means the impulses coming here. The impulses coming from frontal eye field area here, and impulses coming from posterior parietal cortex here. They both go to 4C beta and occipital cortex. And in occipital cortex, they are released before the synapse, in the synapse, after the synapse, and they stimulate the release of nitric oxide via the postsynaptic membrane. The nitric oxide released in the postsynaptic membrane fast forwards the impulses coming from the presynaptic membrane to the inferotemporal cortex. The inferotemporal cortex is the one which analyzes all the impulses. So the rapid transmission across the blocked synapse because of nitric oxide stimulates within one session the vision improves. Maybe not to 6, but it does improve by one session of 45 minutes. Please use the mic.
Any study with patching and without patching?
I
What is the
don't I
difference?
don't patch at all. Since started using the Orthoptek, the eye is not patched. There is no need to patch. How does patching work? You don't know. You think that it works in some way. No, it's not that way. The patching does not work because it doesn't do anything to the 4C beta. Just because I cover this eye does not necessarily mean I have to fixate with this eye. Does not necessarily mean, because fixation is an active process where different parts of the brain are involved. So if I patch this eye, if this eye is amblyopic, it does not take up automatically fixation.
Eccentric fixations?
There is nothing called eccentric fixation. I need about 20 minutes to explain, but I'll explain to you. If you have time, I'll explain. There is nothing called eccentric fixation. It's a wrong concept which has been drilled into our brain for so long, and therefore everybody asks eccentric. Eccentric fixation, Orthoptek works very well. If you have just 15 minutes, you come to me, I'll explain to you, because I have up to 10:30 time before I go to another hall. Okay? Thank you very much. Let's call it a day. Thanks a lot, all of you.